Uh, all right, we are going to talk about something like evaluation and diagnosis of dementia for primary care teams. We're going to go through the basics. We're not going to be quite specific or extremely sophisticated in terms of diagnosis or evaluation. We're going to try to keep this presentation in a simple and dynamic way. Next slide, please. This is the agenda: definition, common causes of dementia, stages of Alzheimer's disease, evaluation of memory loss, and treatment. Next slide. Why diagnose and treat of memory loss is important? That's the main question that I got from patients, even for clinicians. And I guess the big argument for them is if we don't have a clear treatment for dementia, why are we spending a lot of time in terms of making a diagnosis? And probably we're doing this one for many reasons. One of them is many times when we assess patients with memory loss, we don't have a clear diagnosis for them. And that's a question. I got many patients that come to my office and say, oh, this patient is extremely agitated, he has confusion, we don't have any clear diagnosis for him or her. And that's the most important thing for us in terms of diagnosis, to have a clear diagnosis. The other thing is planning. Most of these patients, if they have some kind of mild cognitive disorder, they're able to make decisions by themselves. And they need to make decisions in terms of medical power of attorneys, financial decisions, and they're able to do this one. If this patient just progressed to late stage of dementia, probably they're not going to be able to make decisions by themselves and going to create different kind of problems. The other reason for this diagnosis and treatment of memory loss is the current medication that we have can help us to control some behaviors and also can slow down the dementia process. There is no clear treatment, there is no definitive treatment for dementia, but can help us to slow down the process. The other thing, if the patient, the demented patient just progress in terms of the symptoms or behaviors, these patients are going to develop a very complex situations, and the families and caregivers are going to need guidance and also going to need support in terms of managing these behavioral issues. And we are going to talk briefly about the disease-modifying treatments. That's a new trend in terms of management of dementia. More of these new treatments are in trial process. There's in terms of research, and we're going to review a couple of them. And the most important thing in terms of memory loss, quality of life is our main goal. It's not quantity anymore, it's quality of life. Next one, please. This is the DSM-5 criteria for diagnosis, and also this is the definition of dementia. Dementia is not being used anymore. We use a major neurocognitive disorder, was the main change in 2013 by the DSM-E, which is led by the American Psychiatry Association. Still, we can still use in dementia, but I think the technical name for this one is major neurocognitive disorder. And this is the major changes from 2013. In the past, if somebody had dementia or had the diagnosis of dementia, should have memory problems. That was something like a specific requirement in order to make a diagnosis of dementia. Right now, everything changed from 2013 because any cognitive deficit qualified the patient to have a major neurocognitive disorder. When we're talking about cognitive deficits, we are talking about complex attention, executive function, learning, memory problems, social cognition. Any of these changes or combination of this one are going to help us to make a diagnosis of major neurocognitive disorder. I want to be clear about this one. In the past, you used to have, you should have memory problems in order to have this diagnosis. Right now, since 2013, any combination of cognitive domains, including memory problems, complex attention, executive function, qualify you to have this diagnosis. The other big thing from 2013 is the correlation between the cognitive changes and the functionality. If patients are having problems with activities of daily living or instrumental activities of daily living, probably we correlate with the cognitive deficit, are going to qualify to have the diagnosis of major neurocognitive disorder. Of course, we have to rule out delirium. Of course, we need to rule out any other mental disorder as well. Next slide, please. Causes of dementia. Next slide. I like this slide is coming from UK in terms of they're not giving us percentages about Alzheimer's disease or vascular dementia. We know that Alzheimer's disease is the #1 dementia around the world and also in the United States. But this is a big thing about this one. I want to share this kind of understanding. Alzheimer's could be the #1, vascular dementia could be the #2, but there is something called mixed dementia. There's a big study from Woolfolk 2019, and they did biopsy of brains for, that was different tertiary centers, different memory clinics, and they did a biopsy of the brain. And the report is quite interesting because probably more than 50% of the patients that they have a biopsy of the brain, they have mixed findings, meaning they find big markers for Alzheimer's disease, something like beta amyloids and the tau proteins. And also they found some kind of microvascular changes, which is characteristic of vascular dementia. And of course, different kind of things for frontotemporal and Lewy body as well. Meaning that the mixed dementia probably is something that we need to pay more attention because it's a combination, again, memory problems, dementia could be a combination of different kind of factors or different kind of types of dementia. Next slide, please. And this slide is one of my favorite ones in terms of telling us that we can find pure forms of Alzheimer's dementia or vascular dementia, but most of the times, if you are more than 80 years old, you are going to have this nice combination of findings that define Alzheimer's dementia, something like beta amyloid proteins or tau proteins, but you're going to find the same findings after doing a brain biopsy for somebody who's having vascular dementia or frontotemporal dementia. Same thing happened with vascular dementia. Same traits are going to be found in Alzheimer's disease or Lewy body dementia, meaning that it's not just a pure form of dementia that we're dealing with. There is probably, after 80 years old, a combination of different kind of components of different types of pathological findings. Next slide, please. I like this one in terms of the clinical definition and scenarios about how we're dealing with different type of dementia. Clinically, Alzheimer's disease is going to show most of the times memory problems, short-term memory problems. We are going to have different cognitive domains that are going to be affected, and you're going to find some kind of worsening of different qualitative or different kind of skills through the years. And also you are going to find this kind of patients problems with activities of daily living, and they're going to be less independent. And probably these kind of findings are going to be quite remarkable in the other types of dementia as well. But we need to pay attention to a couple of things that are going to help us to make the proper diagnosis. If somebody's having, let's say, memory problems, in addition has Parkinsonism, different kind of symptoms of Parkinson's or visual hallucinations, probably we're going to think about Lewy body dementia. If somebody has, in addition to Alzheimer's disease symptoms, some problems or some imaging MRI findings with microvascular changes and variable progression of the memory problems or any cognitive disorder, probably let's take close attention to vascular dementia. If somebody is less than 65 and having behavioral issues that many times can be confused with psychiatric problems, and sometimes having problems with language disturbances, problems finding words or unable to complete sentences, let's pay attention to frontotemporal dementia. One of the big issues that I encounter in my clinical practice is patients have memory problems or cognitive disorders related to medications. They're taking benzodiazepines, they're taking barbiturics, they're taking even antipsychotic medications when they don't have a clear indication for these medications. And also depression. That's a big factor when somebody has memory problems. And we're going to review a little bit about depression, and we're going to be the prevalence of this disorder with patients with memory problems. Next slide, please. Stages of Alzheimer's dementia. Next one. This is one of my favorite slides. It's coming from 2020. That's the Alzheimer's Association Facts and Figures. That's the name of the article. And we have seen that Alzheimer's disease is a continuum, meaning that different kind of stages are just going to be extremely related. We realized that there is some kind of preclinical Alzheimer's disease, meaning that the patient doesn't have any kind of symptoms, but if we're going to review the brain, we are going to find early stages of beta amyloid plaques and tau proteins in the brain, but the patient doesn't have any kind of symptoms. Then is going to progress to mild cognitive impairment. With this patient, probably is going to have mild symptoms, but is still functional, able to drive, able to write checks, able to have a normal life, but again, it's going to have some kind of cognitive deficits. And then we are going to move towards the right, and we are going to see the classic findings or the classic stages of Alzheimer's disease, mild, moderate, and severe. And if you're going to see, and we're going to pay a close attention in the next slide, the most important thing is the cognitive disorders are going to get worse, and the functionality of the patient is going to be compromised as well. Before going to the next slide, I would like you to pay attention to the preclinical Alzheimer's disease and the mild cognitive impairment, because these two stages are going to be the big targets for the new medications, the disease-modifying medications for Alzheimer's disease. These medications are not going to be designed for mild, moderate, or severe. All these new medications are being designed to be given to the patients in the preclinical and the mild cognitive impairment stages. Next slide, please. This is the correlation between, if you see in the left side, we have the clinical, preclinical, and mild cognitive impairment, and we're going to see all the findings, some kind of memory loss, mild ones, but the patient is still functional. In the far right, you're going to see the severe and late stage of Alzheimer's disease, that we're going to see all these classic findings that they don't have, they have problems with short-term memory, long-term memory. They're not going to be able to have a functional life. They're going to have problems sleeping. They're going to have behavioral problems. They're going to have problems swallowing. They're going to have infection. We're going to have pneumonia, and they're going to die. And then you are going to see in between, in the mild and moderate Alzheimer's disease stages, a combination of different kind of findings and something in between. Next slide, please. Evaluation of memory loss. I really like to, thank you, that's perfect. This is the big difference, how we evaluate demented patients from a classic evaluation in the left side. In dementia, whatever the patient is telling us many times could not be a reliable source. We need a family, because family is going to be the ones who are going to help us to put everything together and get the proper information from the patients. In the dementia evaluation, we need a mental status examination is critical. We have different kind of tools in order to do this mental examination, and that's very important, which we don't use in a classic medical evaluation. Then we are going to need laboratory studies, but this one is going to help us to rule out the diagnosis. It's not going to help us to rule in. And of course, since 2010, there's a big indication about doing imaging, which is going to be critical, and I'm going to let you know why. Next slide, please. When I do my interview, the initial interview with my patient with any kind of cognitive deficits or concerns from the families about memory loss, I like to concentrate my questions in these 6 points. complex attention. I ask if this patient is able to read a book and remember this one. I pay attention if this patient is able to follow the conversation. I'm trying to see if this patient is engaged during the conversation or probably just thinking different kind of things or looking at different person during the conversation. Just try to be sure that this patient has full attention at that time. Executive function, it's very important to explore a little bit if this patient is able to make, is able to have decision-making capacity, able to make plans, learning and memory, short-term memory, long-term memory, able to read a book and encode information and able to retrieve this information after questioning the patient. Language, I like to ask the patient if he has some kind of problems finding words. If this patient is able to complete a sentence or requires somebody else to complete a sentence for him or her. Perceptual and motor, many times is the patient able to drive and talk? Is the patient able to walk and talk? Is this patient having any kind of sensory deficits? Social cognition is another point that I really like to explore extensively. Be sure that the patient is able to recognize emotions. I like to explore the theory of mind for these patients. Next slide, please. The neurological exam, it's a very important aspect in order to rule out two different kind of pathologies or help us with the diagnosis. If we are thinking about some kind of vascular dementia, probably going to look for some kind of focal weakness, asymmetric reflex, sensory loss. We are also going to look for extrapyramidal symptoms, something like tremor, rigidity, gait disorder, thinking about different kind of symptoms you can find in Lewy body dementia, for instance. Signs of possible dementia, meaning that the frontal lobe of the brain can be compromised, is going to be the snout reflex, the grasp, palmomental reflex, apraxia. Unusual signs, something like an alien limb or eye movement abnormalities that you can see in primary supraventricular palsy. That's another kind of dementia. It's not very common, but we can find this kind of signs as well. Next slide, please. We geriatricians, we pay a lot of attention to the functional status. As I already told you, during the definition of dementia, we need to correlate the cognitive deficit with the functionality of the patient. And we really like to explore about activities of daily living, something like bathing, dressing, eating, walking, using the toilet, and also the IADLs, instrumental activities of daily living, which is preparing meals, taking medication, shopping for groceries, writing checks. I think this is a key element in order to make the diagnosis, to know about prognosis, and also to provide advice to the patient and also the families after assessing the functionality of the patient. Next slide, please. Cognitive tests and questionnaires. Next slide. What's the purpose of these cognitive instruments? And we're going to review each one. There's a couple of very important points here. Some patients, they have some kind of mild cognitive deficits after having a normal conversation. Many times we're going to be unable to pick up this one, but having something like a standardized instrument is going to help us to ask different kind of questions and probably document different kind of deficits. That's going to be helpful in order to make a diagnosis. For patients and families, the big question for them is what's the stage of the impairment? And these kind of instruments are going to help us to correlate with the cognitive deficit and also functionality in order to know if this patient has a mild, moderate, or severe stage. And also help us with the diagnosis. Many times it's quite difficult to make a difference. This is Alzheimer's, oh no, this is Lewy body, or that's a mixed presentation. That's the main purpose for these cognitive instruments. Next slide, please. This is the MMSC. I think that's one of the most or very well-known screening tests that we use for dementia or memory problems. What's the problem with the MMSC? This instrument doesn't help us to make the proper diagnosis of early stage of dementia. Also doesn't help us to make a proper diagnosis of executive dysfunction for the patients. And the third thing, you have to pay for this one. Next one. This is the Mocha. There's a big movement right now in order to replace the MMSC by Mocha test. It's a great test in order to make the diagnosis for early stage of dementia. It's a great test in order to assess executive functions for the patients, and also it's for free for now. And you need a small training just to do this test, to perform this test properly. It's going to take you between 10 to 15 minutes to complete the test, but it's going to get you a lot of information in terms of the cognitive status of the patient. Next one, please. Many people ask, and I have residents, fellows even attend and saying, why are you requesting neuropsychological testing? I mean, you're probably clear about the diagnosis. We already have an abnormal Mocha test. We already got an MRI. Family saying that this patient is extremely confused, but you want to go for the neuropsychological testing. There's a couple of reasons for this one. One of them is sometimes you evaluate the patient has mild cognitive disorder. I mean, probably doesn't have a lot of abnormal findings. Families are still concerned about the mental status of the patient. Probably that's the time that you can just move forward and try to just explore a little bit more all the cognitive domains of this patient. Sometimes you have patients that they have some kind of high premorbid intellectual functioning, something like physicists, I don't know, lawyers, that they have this kind of rate of reserve in terms of intellectual functioning. And probably for these patients, we are going to need to explore a little bit more. They're going to do great during the Mocha test or the MMSC, and probably we need to explore a little bit more, dig a little bit deeper in order to get more information about the cognitive domains. Of course, it's going to help us if somebody has some kind of pre-existing cognitive problem, something like mental retardation, Down syndrome, TBI. Also, it's going to help us to distinguish from major psychiatric conditions, and also probably going to help us to make a proper diagnosis in terms of this is Lewy body dementia, this is Alzheimer's disease. Is going to provide some kind of support in terms of the diagnosis as well. Next slide, please. We already talked about depression, and it's something that I just want to emphasize. Every time that we're going to evaluate somebody for memory loss or probably, of course, a major neurocognitive disorder, there's a big study showing that probably 50% of the patients that they have Alzheimer's, they have dementia. And there's a high prevalence of, depression. There's a high prevalence of depression in the community, 1 to 3% or 10 to 50% in the nursing home settings. That's why we need to assess memory, depression in somebody coming to see you for a memory evaluation. And most of the times, if the patient arrives and say, hey, I'm really concerned about my memory, I would like to be evaluated. Many times I'm going to do a good evaluation of depression for this kind of patients. If somebody has memory problems, most of the times come to your office and saying, I don't know why I'm here. My family just brought me here. My memory is perfect. I don't know why they are concerned. Okay, probably this patient has memory problems and he's not extremely depressed. Next slide, please. And this is one of the greatest instruments that we use in order to assess depression. The GDS, that's the short form. If you're going to have more than 5 points, it's going to be suggested that you may have depression. I want to share this instrument with you as well. Next slide, please. Laboratory studies. There's a big controversy about what kind of test you're going to require, we are going to order in order to make a diagnosis of memory problems. The the bottom line for this one is you don't need a lot of tests. You are going to require just a basic lab test because this one is going to help us to rule out, but it's not going to help us to rule in the diagnosis. Next slide, please. And if we're going to talk about the basic labs, we're going to be CBC, CMP, B12, TSH, probably going to consider RPR, even though syphilis is not highly prevalent as used to be in the past. Probably Lyme disease in the northeast, EEG, probably sleep studies, yes, probably going to request this one. Many people is talking about the genetic testing, the APOE. Let me tell you, you can be positive for a genetic test, but doesn't mean that you're going to develop memory problems. That's a different talk about this one, but just to let you know, it's not part of our regular testing. It's something that you can be positive again. I want to repeat this one. You can be positive in the genetic test, but doesn't mean that you're going to develop dementia. Next slide. This is probably beyond what primary care providers needs to know about the diagnosis of dementia, but I just want to mention a couple of things because this is a breaking ground about how we're making the diagnosis of dementia. We're using biomarkers. In terms of biomarkers, I'm going to mention some of them that can help you to make the diagnosis. I'm probably going to provide support in order to make the proper diagnosis for this one. These biomarkers are being used in memory clinics, tertiary centers. We are going to mention, for instance, for Alzheimer's disease, the amyloid beta 42, amyloid beta 40, amyloid beta 38. For tau pathologies, Alzheimer's disease as well. We are going to talk about the total tau, the phosphorylated tau. The TDP can be used for frontotemporal. Syncline can be used for the Lewy body. And again, these tests are being used in the CSF testing. They're trying to do the same thing for plasma. They're trying to do the same thing in saliva. But again, some of them is in research. The CSF is being used regularly in memory clinics to provide the proper diagnosis in terms of dementia. I just want to mention briefly this one. Next slide, please. Imaging. Imaging, that's a big thing as well. Next slide. I'm going to talk about the imaging in terms of structural imaging and functional imaging. Structural imaging, that's something that it's a big help in order to make a diagnosis. We're talking about the MRI. And what are the questions for structural imaging? One of them is going to be if there's an atrophy of the brain, shrinkage of the brain, which goes along many times with different kind of pathologies, something like Alzheimer's disease. You're going to see this one, probably some kind of compromise in the frontotemporal area as well. But it's something that is going to help you in order to make the diagnosis. The other big thing in terms of the structural findings are going to be the microvascular changes that you can see in vascular dementia. Is going to help us, or going to help you to make the diagnosis as well. And the most important thing, at least for me, is doing an MRI. You're going to rule out another pathologies that are going to cause memory problems. Something like normal pressure hydrocephalus. Metastasis, any kind of cancer making a metastasis to the brain, in any mass, and stroke. Many times we can find strokes, microstrokes going to the brain and being the cause for these memory problems or dementia. Next slide, please. The functional imaging are the SPECT and the PET. Probably not being ordered in the primary care setting, but it's a good thing to know about a little bit more about these ones. When are we going to request an SPECT or PET scan? Many times can be used if you have a typical findings, a typical presentations. We need to find out a little bit more. Are we dealing here with a frontotemporal? Are we dealing here with something like just Alzheimer's disease? Somebody less than 65 years old, even though it looks like they have some kind of cognitive deficits, but let's find out a little bit more of what's going on here. And also they're going to help us to make a proper diagnosis and be clear about what kind of dementia we're dealing with at this point. Next slide, please. I like to talk about this one. We already talked about this one briefly, about the biomarkers in the cerebrospinal fluid test for beta amyloid, tau proteins, and amyloid PET scan. It's quite interesting. The amyloid PET scan can just help you to make the diagnosis for Alzheimer's because they're going to have specific findings. Next slide. This is something, I'm not going to spend a lot of time for this one, but I just want to give you an idea that the diagnosis of memory problems or Alzheimer's, they are a combination of different kind of biomarkers and different imaging as well. As you see at the initial stage of the memory problems, the beta amyloids in the CSF and probably plasma right now are going to be abnormal. And through the process, then we are going to see that tau is going to be able it's going to help you to make the diagnosis through the progression of the disease. But at the end, you're going to see that the patient are going to have some kind of cognitive deficits, and also they're going to lose functionality. Next one, please. Treatment. Next one. The FDA approved medications for memory problems are donepezil, galantamide, Namenda, ribastignin, and this nice combination, Nemsaric, Namenda, and donepezil. These medications are not going to be able to cure. It's not a cure for memory problems. It can help us in terms of controlling some kind of behaviors, are going to help us to slow down the process. Probably there's not a big evidence, there's not a lot of support. We're using this one because we find some kind of benefits for the patients, side effects, GI problems, most likely. Probably with Aricept, I'm going to mention bradycardia. Let's be sure that this patient is not having a combination of beta blocker, calcium channel blocker plus Aricept is going to make the heart rate quite low. And that's something we have to be very careful about this one. And don't stop the medication. If you have decided to stop the medication because there's a progression of memory problems, you have to taper the medication, of course. And again, every time you're going to prescribe this one, just let the family members and the patient about the possible GI side effects. Next one. I'm just going to talk a little bit about this one. This is the disease-modifying treatments. We have two types of disease-modifying treatments. All of them are on research stage. It's not something that we're using in any kind of clinical scenario. There is nothing that is being prescribed. If you see in the right side, you have the passive immunotherapy. This is a big one. I don't know if you heard about the Biogen. Is the aducanumab. That's something like a passive immunotherapy, was close to be approved by FDA, but FDA is requesting more research before moving to the next stage. And these medications are being prescribed, as I already told you, if you have a preclinical memory problem or you have mild cognitive impairment stage. That's the requirement to use these ones. But again, they're in phase 3. In the research stage at this point. In the left side are the vaccines. Most of these vaccines are just on phase 2. There is no vaccine in phase 3 yet. And these vaccines are directed against the beta amyloids and the tau proteins, all of them. Just to give you an idea what are we doing in terms of disease modifying treatments. Next slide, please. The dementia process or major neurocognitive disorder is going to progress in spite of our best efforts. And we are going to have patients with behavioral issues. We are going to have patients that are going to be aggressive, they're going to have hallucinations, they're going to try to escape from home. It's going to be quite difficult to control these kind of symptoms. And I advise a non-drug approach and also a drug approach that we're going to talk in the next slide. But the non-drug approach, it's very important. I think that's the most important way to deal with these problems. We are going to pay attention to personal comfort. Many times this patient can have pain. If you treat the pain, probably they're going to get better. You have to avoid being confrontational. Many times we have to go along with the flow. The patient doesn't want to eat. We can say that's probably fine. After 15 minutes, probably the patient is going to forget everything and he's going to be able to eat. We have to redirect the patient. That's the most important element in order to control the behaviors. A calm environment, probably something like classic music. Be aware that the patient could get extremely anxious if somebody's screaming. Adequate rest. That's very important to acknowledge requests and respond to them. I heard a couple of times saying, oh, this patient is demented. He doesn't realize about anything else. But I don't think that's the case. Many times we have to just politely approach the patient, let them know that we are hearing his request and try to respond to them. Don't take these behavioral issues personally because the patient is not able to make the right decisions because of the medical problems that they may have at that time. Next slide, please. Treatment for behaviors. If the patient is quite agitated, having a lot of hallucinations, we need to have something like honest discussion with the family. We can prescribe antipsychotic medications, but remember, antipsychotic medications are not FDA approved. And the risks about this medication is they increase heart attacks, strokes, falls, bleeding. And we need to talk to families about risk and benefits. 90% of the families, they accept the risks because they want to keep the family member calm. They want to keep the family member at home. They want to be able to redirect the patient, and they need medication in order to help them. In the inpatient service, probably can use Halvo a lot because we can give PO, IM, IV. In the outpatient service, probably use a lot of Seroquel or Zyprexa. And I really like this last one is the pimavanserin. That's a medication which just works in the serotonergic receptors. All the medications, the rest of the psychotic medication work in the dopaminergic receptors, and they're going to create more problems. But this one, pimavanserin, that's a medication was approved 6 months ago. It's a great medication to control symptoms. We already talked about antidepressive medications because there's a big correlation, association between depression and memory problems. And if we cannot use antipsychotic medication or antidepressive medications, we can try something like seizure medications, mood stabilizers, something like valproic acid or carbamazepine. I think this is the last slide. Yes. All right. Thank you.
Thank you so much. Thank you so much, Dr. Navia. That was wonderful and super thorough. So we truly appreciate it. I wanted to open it up for any questions or comments from the group. Jen, I see that you were able to join us. I'm so happy you could join us today. If you had any comments or questions as well, please feel free to unmute or chat in, everyone.
So I'm Jennifer Boyd. I'm a physician assistant in a community health center, New River Health Center in Fayette County. Thank you. That was a wonderful presentation. And I have been wanting to prepare cases, and I just haven't, with the holidays, and then this is my first day back, so I just haven't got any cases. But this presentation puts me in mind of so many, issues that have come up for me with different patients that I've had. And one, everything's kind of mushed together in my mind right now, but in particular, one thing that was interesting for me to hear you talk about is depression and the behavioral changes. And particularly early in my career, I recall seeing people who had clear evidence of depression and that we had suspicion for some memory changes. And I started treating them for the depression right away before I was even sure if there was memory impairment. And so can that sometimes guess I sort of want to say delay the onset, but I guess that's not really, it just depends on the, I guess, the cause of memory and cognitive impairment and memory loss, whether it's going to delay the onset or not. But it seems that could it help?
Definitely. Jennifer, there is two different kind of approaches about depression and dementia. There's a, I mean, in UK school.
And 1 second, they just started a vacuum cleaner outside. I can't hear it. That's okay. I'm sorry, I hate to stop somebody from vacuuming, but I couldn't hear all of a sudden.
Are you okay, Jennifer? That's
yes,
right?
now it's
okay.
better. Thank you.
Yeah, there's two approaches about this one. That's a big one. For instance, the UK, there was a study something like 10 years ago saying that be proactive, right? Let's try and treat depression before anything else, because there's a high correlation between depression and dementia. More than 50% of the patients with mild cognitive impairment or of the dementia with the mild stages are going to have this kind of depression. And then there's a different school that they are thinking about, let's do the proper diagnosis first. Let's use the proper tools in order to make a diagnosis for depression and dementia. If you have somebody who has a moderate to advanced dementia, probably going to be difficult to use the GDS score in order to make the proper diagnosis.
Right.
At the end, and probably this is the approach that many people think that's going to be beneficial for the patient, is doing something like a trial and error. Let's try to prescribe something like an SSRI for the patient, even though, I mean, we're talking about moderate to advanced dementia, and then we are going to reassess through the family if this one is helping the patient to control the behaviors, is helping the patient to control or regain some kind of functionality. And again, that's the best way to approach this situation. If somebody has mild cognitive impairment or dementia mild stage, probably they're going to be able to fill out all the tools that we're using, something like a GDS, make the proper diagnosis, prescribe the proper medication, and just move forward. But if somebody has moderate to advanced, probably can just do a trial and error, prescribe small doses of SSRI, and then we are going to reassess how the patient is responding to the treatment.
Yeah, that's helpful. I haven't used that geriatric depression scale tool, so I might try to start using that. That looked really intriguing to me. Another question I have about medications is you didn't have any tricyclics or tetracyclics listed on, I have tried trazodone, Deseril for sleep when people are having trouble sleep. Is that reasonable?
Definitely. Tricyclic medications, it's a no-no medication for people more than 65. And I'm talking about this one as a geriatrician. That's a medication that is going to cause many problems. And that's an old medication for depression. We don't use these medications anymore. Many times they're being used for pain, for neuropathic pain, but for depression, this no-no medication is going to cause many problems. They have a high anticholinergic burden. They cause cardiac arrhythmias. If you're going to have somebody who is going to be prone to delirium, is a patient who is taking tricyclic medications. It's a no-no medication. There is better alternatives in order to treat depression, like SSRIs. Going to the second part of your question, trazodone for insomnia, for instance,
Right.
It's a great medications. I highly advise to use trazodone or mirtazapine, and can help us, low doses, of course. The only thing with trazodone is I'm going to be cautious if somebody has a history of seizures, because it's going to decrease the seizure threshold, and you are going to have, or you're going to cause more problems with somebody who is taking any anti-seizure medication. If you're going to prescribe mirtazapine, I highly advise to use 7.5 to 15 milligrams, no more than these doses, because that's a big study about this one as well. Just low doses of mirtazapine are going to help you for insomnia. If you're going to use more than 15 milligrams, it's not going to be effective and also being used for depression more than for insomnia.
It's very helpful. Thank you. I hadn't thought about mirtazapine. I might add
Yeah,
that.
or melatonin, that's another one, a great one as well.
I have more, but I don't want to hog the time.
No, you're perfectly fine, Jen. Keep them coming. We love it. I wanted to ask any of the other hub members in the conference room if there were any other additional comments you wanted to add as well. Feel free to unmute and chime in anytime.
We're good right now. Thank you.
Sounds good. Any other questions for the hub members, Dr. Navia?
You know, one of the most interesting things to me about caring for people who have dementia is assisting the caregivers with the behavior changes. And I recently had to coach a daughter-in-law who was convinced that her mother-in-law was just being mean and that it had been there all along, but now she felt like it was her license to be mean. And I mean, maybe that's true, but I think not. And so that slide that you had was helpful, especially that last line, don't take it personally. I think I might have said that to her, but I find that to be a really challenging thing for families and caregivers when there's that kind of, you know, they want people to act a certain way, and whether it's, you know, being verbally aggressive, or whether it's doing things like not being on time when they, you know, for an appointment, and having to kind of prod and stuff like that. So I don't have a question, it's just sort of a comment about that.
Yes, I recognize this one. It's a big challenge. It's something like we see every day with patients with memory problems. And I realized that one of the best tools that we have, and we need to use it, is education. Many times family members, they don't fully understand what's going on in the brain of our patients. Even they don't fully understand what dementia means, major neurocognitive disorders. And probably it's the time that I really like to sit with family members and talk a little bit. I have sometimes at UTC, that's one of the memory clinics that we use, I spend something like 15 minutes before seeing the patient and talking to family members, just to be sure that they fully understand what's going on with the patient. If you don't have the help from the families, you can make the great diagnosis, or you can just talk about prognosis, even you can prescribe medications. But if you don't have the support and a good understanding from family members what's going on, you're not going to be successful. You have to make the family members to be your, I don't know, your partners during this journey. Otherwise, you're going to have the whole family or some family members against you. They're going to call you something like two or three times a week saying, oh, what's going on? It's getting worse. I mean, she's screaming, what I have to do it. I mean, it's something like a big problem. That's why I realized education is the first thing. The second thing is the Alzheimer's Association. They have a great ways to educate families. The webpage is a great source for families, even patients. They have something like MCI, mild cognitive impairment of early stage of dementia. They can just go through Alzheimer's Association and get more information. I think that's a great resource for families as well.
Excuse me, this is Teresa. I'm going to interject. We actually have two really good programs for caregivers. One is understanding and responding to dementia-related behaviors, and then we also do communication strategies, you know, for caregivers. As a speech pathologist, the communication strategies I personally think is the best program that we do, because it's often just, you know, changing our approach to the person with the disease. So you can always refer folks, you know, to me directly, like Dr. Navia said, to the website, because that's what we're here for. That's, we want to partner with you and the primary care physicians to provide that education, to your patients. We want to be that tool to bridge, diagnosis with going home and caregiving, for someone with the disease.
I think it would be helpful if I could use your name. I have been in the habit for a long time, partly because of my own family's history of working with the Alzheimer's Association when my mother had Alzheimer's, and it was so useful for my mother-in-law, and it was so useful for my father-in-law. But I think if people have a name, that might be an additional help for them. I have them call and website, but I think if I could use your name, that would be great.
Oh, absolutely. Absolutely. You always can. I can put you some of my business card even in the mail to you. And so if people come through, you can just give them my card, and that's what I'm here for. That's what we want to do. So.
That's terrific.
And Teresa, if there are any materials that you'd like me to share and distribute out as a whole, and the recap email or anything, just send them my way, and
okay.
I'm happy to do that.
Okay.
Thank you so much.
Thank you.
Any other comments or questions from the group as a whole? Four minutes left. This has been an awesome session, so thank you all so much. Dr. Navia, I know you mentioned tau in your presentation. I was just going to ask you, what are some of the pros and cons to the blood test that helps predict the Alzheimer's proteins in the brain? I'm not sure if I'm asking that properly, but I know you mentioned tau and how there's a blood test that can help detect that. What are some pros and cons that you can share with the group in your personal opinion?
Definitely, Mitra. Just want to make a big disclosure here. The plasma tau and alpha and the amyloid beta protein are just being done in CSF, cerebrospinal fluid. That's what has been done in the big centers, memory clinics. The plasma and the saliva for tau protein is under research. There is a big advance in, I guess, in Switzerland, that the one who are just leading this initiative, University of Chicago as well, they're leading this one, but it's just under research protocols. But there's a great correlation. Let me tell you this one. That was, I attended a conference last December, and they're finding a lot of correlation between the tau protein findings in the CSF and the tau proteins in the plasma, but it's not being done in the clinical settings yet.
That's great. Thank you so much. And Dr. Howe, I noticed you had unmuted. Was there something you wanted to add?
No, I just wanted to say thank you and Happy New Year to everybody. And what a great talk, Dr. Navia. Thank you.
Thank you, Todd. Same thing from here. Happy New Year to everybody. Thank you.
Thank you all so much. This has been wonderful. One quick announcement before we do part ways, just that our next session will be on February 2nd, and Dr. Keith is going to be discussing communication of findings. So keep an eye out for that reminder. And as always, don't hesitate to reach out if there are any other questions, comments, or anything. You can always shoot me an email. So Happy New Year, everyone. I have a feeling this will be a great year for us all. So thank you, and we'll see you guys next time.
Thank you all very much.
Take care.